Είναι μεγάλη μας τιμή να έχουμε έναν καταξιωμένο γιατρό από την Ρώμη, από την Ιταλία. Είναι αυτός ο οποίος είδε την ιδέα του να γίνεται πράξη, να γίνεται προϊόν και ακόμη περισσότερο να γίνεται ένα καταξιωμένο προϊόν που το χρησιμοποιούν πολύ καλοί οφθαλμίατροι, χιλιάδες οφθαλμίατροι στον κόσμο. Είναι ο Carlevale ο ενδοφακός, γιατί είναι πολλοί ενδοφακοί που χρησιμοποιούμε, μιλάμε για χιλιάδες. Όμως αυτός είναι ο μόνος που μας δίνει δυνατότητες σε μια φάση της επέμβασης, όπως ακούσατε από τον Θανάση τον Νικολακόπουλο πριν, η οποία είναι η πιο δύσκολη, δηλαδή να βάλεις έναν φακό εκεί που δεν υπάρχει περιφάκιο. Αυτός ο φακός, λοιπόν, δίνει πρωτόγνωρες δυνατότητες και θα ήθελα να καλωσορίσω τον κύριο Carlevale. I'll have to present in English as well. I'll have the honor to present Dr. Carlo Carlevale. He comes from Italy to present the Carlevale IOL. He has the benefit of seeing his idea to become a product, and also a product which is used by many doctors and very distinguished doctors all over the world. So he will talk to us for about half an hour and maybe more about the lens, the capabilities of the lens, and special tools, and the way you put the lens in an eye with a problem after a cataract operation, or if there is no zonule or there is no capsule. Thank you, Dr. Carlevale.
Thank you, Dr. Mavroudis. I want to highlight that this is the first time that I can speak about the lens, explaining and trying to communicate to you as much as possible. Because usually in a congress, you have just 7 minutes, you have maximum in a course 15 minutes and no more. So in this case, we will have more time, and so I will try to communicate to you as much as possible. Quick history of scleral fixation. Still, one of the best technique is the technique that proposed one Argentinian doctor, Malbrán. Malbrán started to stitch a loop of a single piece PMMA lens to the sclera using Prolene suture. But Prolene suture is very stiff, is sharp, and create decubitation. So since from the beginning he proposed to make a scleral flap to protect the suture and to avoid late decubitation. 1986, more than 20 years, after 20 years only, Gabor Chariot proposed to insert in the sclera a 3-piece foldable lens with the Prolene haptic. But the procedure of Gabor Chariot leave one part of the loop exposed in the sclera. It's deep, but is exposed. That's why Carlevale modified the technique just to cover the sclera, so he proposed one tunnel parallel to the limbus to fixate, to incarcerate the lens, and one scleral flap. But the procedure is more complicated. It's not simple, it's more complicated. After that, Yamani identified and proposed a very clever procedure. He's always incarcerating the lens, the loop in the sclera, but the technique requires a special thin needle. Then there are other models, even Canabrava proposed different models. But on 2011, I had an idea. Why don't put a T-shaped plug on the top of a common foldable intraocular lens? This T-shaped plug works like an harpoon. Once you pull it through the sclera, it opens and stabilizes the lens to the sclera without any need of sutures. And since from the beginning, this is the prototype, this is the actual model round, and since from the beginning, the procedure worked perfectly. And after 2 years, I presented the first 9 cases in the European Congress of Cataract and Refractive Surgery. Of course, what is the idea? To create a plug. This is an experimental video. You see, I mean, the forceps should engage the head of the plug in the center and pulls through the thickness of the sclera. The two wings of the harpoon, once they go on the other side of the sclera, they open. They open and then they stabilize the sclera without any help of a suture. I made this video because somebody asked me which is the best way to engage the plug. So then is certainly the standard technique. Something more about the plug. There is a good paper of Takeshi Sujura that shows how is the thickness of the sclera close by the ciliary sulcus. We have to deal with 1.5 millimeter of sclera. So that's why the thickness of the plug is 0.3, is 300 microns. Why is 300 microns? If it's less than 300 microns, the plug is too thin, so it will slip back in the sclera, in the vitreous. So it must be sufficiently hard to hold, to make its job. If it's too big, it creates a deformation, a bulging of the sclera. These are two OCT pictures, and they show how the plug is buried in the sclera, and there are no modification of the sclera. This is important because now other doctors, they are trying to insert everything on the sclera, any kind of loop on the sclera. Even rigid PMMA lens on the sclera loop. It's not like that, because there will be a huge modification of the surface, so there is a higher risk of late decubitation of the loop. For example, this is a Dexen. Dexen is thicker, 150, 200 microns. And you may see how it works. I mean, the sclera is not bulging, it's okay. It's like the plug. So the maximum thickness we can insert in the sclera is 300, 350 microns. If you insert something thicker, the sclera will be modified. This is a Prolene loop from anterior segment OCTO from Agarwal. Now I have modified the plug again. This is the prototype. This is the standard. Now there is a new model. You see, this part is more conical. Why I have and the neck is thicker. This plug is a little bit bigger. This one is shorter, because I want the plug to be pulled back to pull back in the sclera, deep in the sclera. This conical shape should reduce the risk of late decubitation of the plug. But this lens has other things inside. Of course, there is an angulation, because you don't want the loop to touch continuously the root of the iris. Second, there are some notches. These notches between the optic disc and the loop create a better adaptation to different ciliary of the different diameter of the ciliary sulcus without modification of the distance between the cornea and the IOL. So the refractive predictability is much better. Then you may see the loop is very big, is wide, and stays steady in the ciliary sulcus. So this lens will have a very good three-dimensional stability. One of the complication of the scleral fixation lens is that sometimes the lens can tilt. This wide loop will stabilize the lens and the ciliary sulcus. Which technique? Of course, you have to protect the plug with the sclera, or with a scleral flap, or with a groove in the sclera, where I will show you the technique. Once you have done two scleral flaps, you punch at 1.5, then insert the microforceps, and then you engage with the microforceps the plug of the leading optic, and you externalize. Is self-centrating the lens. With the other, the plug of the trailing optic, you engage it with the forceps and then externalize it. Then you just need to suture the pocket and the conjunctiva. Follow up at 4 years. The slit lamp photo shows that there are no sign of decubitation. Anterior segment OCT that shows where is the plug buried in the sclera. Second technique, you make a radial cutting, then with the crescent, you make two small pockets on the two sides. Then you perforate at 1.5, engage the plug of the leading optic, you should notice that you have to, first you have to engage the plug, and then you have to insert the lens in the anterior chamber. Otherwise you may drop the lens in the vitreous. Same thing with the trailing optic. And then with an instrument you have to put the two wings of the plug in the small pocket you have previously done. I suggest you now, in the beginning I was not making suture, but now I'm putting one suture because I have risk, there may be a risk of late decubitation. Again, slit lamp photo that shows how is the plug. And these are anterior segment OCT that shows where is the plug buried in the sclera. Tip and tricks. Oh, this technique works well, but is extremely standardized. If you don't follow the rules, you will have problem. Anyway, you will have problem. First, is mandatory to have two curved microcoaxial forceps. You can use also some disposable forceps and you can bend it. Around 30% you can bend it. If you will bend more, the forceps will not work. Why is important? Because if you have a deep set eye, or if you have a big nose, a big frontal bone, you will have a lot of problem with the forceps. You will not engage the plug. Always try the forceps in the scleral hole before inserting the IOL. Which is the best instrument to make a hole? The needle. The common syringe needle will make a round hole, because if you will use a sclerotome, you will have a slit-shaped hole, but you want a round hole. That's typical complication. It's a relatively big lens, so during the loading of the lens in the cartridge, you must be careful that all the parts are deep in the cartridge, because otherwise it's very common to snatch some part of the lens, because the lens is catched between the cartridge and the rubber piston. So you will insert the lens in the anterior chamber and you will see that it's broken, or some part of it is broken. Always engage the plug and before inserting the IOL, because if you insert the lens in the anterior chamber, it may fall down in the vitreous. And as all the technique, scleral fixation technique, it's a relatively difficult procedure. But the most difficult part is to insert with one end and to hold the plug with the other end, with the microforceps. That's the critical step. always sculpt a wide scleral pockets, 3.5 by 3.5 or 4 by 4. That's ideal, because you don't want to have late decubitation of the plug if you make a small pocket. Always suture the plug and the conjunctiva, otherwise you may have complications. Complication. You may have an intraoperative complication and late complication. The most common complication is you may break some part of the lens. If you don't break the optic disc, in the majority of the cases you can use it again, because you can stitch it, you can suture some part of the loop to the sclera with a Prolene. I'll show you then. So I mean, not necessary to remove the lens. You may break a part of the arm, the 4 arms that are connecting the optic part to the loop. If you break one, you don't need to remove it. It will be anyway steady, so leave it. If you will snatch the plug, you can try to find that part of the loop and put one suture. Of course, you can drop the lens, and you may drop one loop. So the lens can fall down like this and float in the vitreous. So one is engaged and the other one is free. So you have to find some instrument to take and to pull it up. Wrong shape, I told you, is mandatory to have a curve. Don't start the procedure without any curved forceps, because you will have, in the majority of the cases, you will have problem. Because you cannot bend the forceps in a way that you must be parallel to the iris. Scleral hole. If the hole is too big, there will be some problem, because you may have a leakage and the loop can, the plug can go back in the vitreous. If it's too small, you may squeeze with your forceps too much the plug, so you may damage the plug. So the ideal hole is 23. 25, I mean, you need a particular instrument, but 23 is a very safe size. Doesn't make any difference to make a hole of 23 and 20 or 25. So I suggest you 23. And just to explain you, I never had any leakage from this hole. Carlevale mentioned that with his technique, the glue technique, sometimes there was some leakage. In this case, the plug stops exactly the hole, so there is no leakage. Then the most common, also very common complication is wrong plug engaging, but I will show you in the video now. Late complication. Plug decubitation or late drop of one loop. What does it mean? That you fixated the lens perfectly, the lens stay in the place, and then after 3 months, 1 week, you will see the lens floating because one part is free. Usually you have damaged the plug during when you are pulling the plug through the sclera with a too much strong forceps, or you have made a very small hole. This is not a complication. I have not inserted the cartridge in the anterior chamber. So you see, I have grabbed the plug, then I have inserted the lens, but the lens was outside. But the lens is very elastic, so it's not get damaged. This is not a good instrument. The surgeon used a very big instrument, and then on the way back, even enlarge the wound. This is the case of when the hole is too big. What to do? You can continue. You have to continue. If you feel that the plug can be pulled back easily, ask your assistant to hold the plug and then put one suture. This is the classical complication. When, due to the visibility, because sometimes it's not easy, you engage something which is not the plug. You are happy, you externalize something, but you don't find the plug, because the plug is opened inside. You have only a cluster of a jelly loop. What to do? You have two options. You can leave like that. You just put one suture, because then you will cover with your flap, and it will stay like that. The only thing is that after 5 years, you may have some erosion of the root of the iris, because the lens, the loop will be tilted somewhere, so it may touch the iris root. So in this case, the surgeon has stitched the loop, some part of the loop, but not the plug. There is a Greek colleague, Stylianos Kandarakis, that presented the same complication, and he was lucky because he made a relatively big hole, so gently pulling the part of the loop that was externalized, he reached to externalize the plug. But in this case, the hole is big. If the hole is small, it's better to leave like that. Now the plug is in its right position. If the hole is too big, you just need to suture it. Anyway, I repeat, the most difficult part is, but you can train today, is to inject the lens with one hand and try to engage exactly the plug with the other hand. Now it's okay. This is very strange case happened to me. I mean, this was a luxation of complex back IOL. What I did, I inserted viscoelastic between the vitreous and IOL, so I lifted the bag. Then I inserted the lens behind the vitreous and the first lens, but I could not engage it properly with my forceps, so the plug is not out. It's still inside the eye, just behind the iris. What to do? What I did, I started to fixate, to externalize the second loop, the second plug. So at least one of the two loops is fixate to the sclera. Then I have removed the lens, the complex bag and IOL. I have to inform you that if you have a small pupil, it's very difficult to implant this lens because you will not have a visibility. Because to engage the plug, you need to see it. If it's not visible, it will be a big problem. In this case, what I've done, I put my Dratic, then I have with a Sinski hook, I have moved the IOL till I could see the plug. Once you can see the plug, you just can hold it and you can externalize it. I did 3 cases like this. 3 cases, I have explanted one lens and I have implanted a scleral fixated lens without touching the vitreous, and worked perfectly. Of course, you have to prepare the cutting, all the cut or the pocket before to open the eye. But it worked perfectly. Which is the future? We know that many material, they can stay on the sclera, because the future of the scleral fixation is to find something that we can put on the sclera without decubitation. Because the problem is that if you will leave this lens, you want to cover only this lens with the conjunctiva, you will have, after 1.5 years, you have something like that. Anyway, you can repair it. I did only once, but I have forgotten to record it. But it's not so difficult, I mean. You have to remove the conjunctiva, to start to make a groove up and down to the plug, and create some small space in the sclera, and then put the plug in between the 2 layers in the sclera, and then stitch it with nylon, not with Vicryl. Anyway, the ideal scleral fixated lens will be a lens that can stay in the, can be fixated to the sclera without any pocket or without any groove or small pocket to the sclera. And this will be the future. We know that at the moment something can stay on the sclera without decubitation, but other things, sharp things, they cannot stay. Also, it's important where is this material, because if is deep in the fornix, usually create less risk. We have less risk of decubitation. But if it's close by the limbus, there is much more risk of decubitation. Even quantity, we know that some big pieces can create decubitation, and small pieces, if they are not sharp, they can stay. But this is the future. This is the future. Okay? If somebody will have some new idea, I mean, how to fix a lens to the sclera, it will be the future. Okay? Thank you, everybody. Thank you, everybody.